Hello there, I'm going to talk about translational research for McArdle disease. Again, when you're planning a clinical trial, it's really important that you have the right outcome measures. And for somebody with McArdle disease, we need an outcome measure that assesses what happens when you exercise. So outcome measures that we've used for clinical trials have been a 12-minute walk test, and also a cycle test, and these tests have been used widely and we know they're safe. Before any drug can be licensed, it's really important that there has been an assessment of that treatment on quality of life. So all trials should have a quality of life assessment included in them. And again, we could look for questionnaires on pain and fatigue. Frequency of acute rhabdomyolysis is a tricky one because how do you standardize that? And I think pain is also tricky because it's very subjective. But we could incorporate those in trials and they would give us some information, but they would not be particularly useful, I don't think. All trials would need blood tests for safety monitoring. I don't think blood tests are very useful though for monitoring the efficacy of a drug. In McArdle disease, everybody has a raised creatine kinase, but we know that that doesn't correlate with how well or how difficult they find exercise. And so CK is not a very good outcome measure. If we're looking to upregulate the brain isoform of phosphorylase or do a gene therapy trial to express glycogen phosphorylase in muscle tissue, then really what you would need is a muscle biopsy before treatment and after treatment to see if that enzyme is expressed. Another test that you can do is a non-ischemic forearm test. So this is when the person is asked to exercise their hand by squeezing something really tight for 10 minutes, and blood is taken every minute during that procedure. And those blood tests are to measure lactate and ammonia. And here you can see in red, in the normal person at baseline, the lactate is 1.1 micromoles per litre. The ammonia is 30 micromoles per litre. At 4 minutes into the test, the lactate is 4.94 micromoles per litre. And the ammonia is 41. So there's been a big increase in lactate, and then the ammonia has changed only slightly. At 5 minutes, the patient can rest, but the blood tests are continue, and you can see the lactate coming down. In the person with McArdle disease, you can see the baseline lactate is 1.8 micromoles per litre, but at 4 minutes, it's still only 1.3 micromoles per litre, so it has not increased. So this shows, as I've shown in my previous slide, that people with McArdle disease cannot make lactate. And the ammonia has gone sky high. It's gone from 90 micromoles per litre to 514 micromoles per litre. So this potentially could be a good outcome measure, particularly if you're trying to increase the amount of enzyme present in the muscle. This is an example of a 12-minute walk test. This is where we ask somebody to walk as far as they can for 12 minutes. We measure their heart rate each minute, and we also measure their rating of perceived pain using a Borg scale. And the thing is that the patient is asked not to walk so fast that their pain is greater than 4. So they have to keep their pain level less than 4. And what you can see very clearly, both from the graph here and from the chart, is that there is a peak in symptoms at 6 minutes. So the heart rate becomes very high. Here you can see it here. And pain is pretty high too. And the patient has slowed down because they're finding it uncomfortable. But here, somewhere between 8 and 9 minutes, there's a big drop in heart rate, and this is where the second wind has begun. And after that, there is a gradual increase in heart rate, and this is what we see in healthy people when they do the 12-minute walk test. So this test can show us the second wind, And then also we can measure the total distance that somebody walks in that 12 minutes. So this is data from 75 patients. And you can see there's a nice normal distribution. So if I was planning a clinical trial, I would only want to include these people in the middle as participants, because these people at this end are much milder, and therefore if we're doing a trial we may not see as much improvement, and so that could impact on the results of the trial. And likewise, these people are so debilitated, again we may not see much improvement. So this is why doing a natural history study to see what happens in people on a daily basis for outcome measures is very important. We can also see here that if we assess quality of life using a test called the SF36, that it correlates very nicely with the distance that people walk on the 12-minute walk test. So again, you can see these people who walk less than 500 meters have much lower quality of life scores. So again, if you included these people in the clinical trial, they could bias the trial to make us think that the results are not as good as they are, for example. So we'd always want to include those people in the middle who are fairly average for the condition. Natural history studies are also very important, particularly if we want to look at muscle strength and look at symptoms. So this is a paper we published very recently. Chiara was one of my clinical fellows, and we've looked at natural history data of 197 British patients with McArdle disease. What we can see is that they nearly all had symptoms before the age of 10, but they weren't diagnosed until they were 34, so a big delay between diagnosis and symptom onset. We also know that they nearly all have a raised creatine kinase, which is a blood test, a muscle enzyme, that they all get symptoms of muscle discomfort and weakness with exercise. Not everybody recognises the second wind, but if we have a good outcome measure, we pick it up, as I've shown you on the 12-minute walk test. But also, as you can see, not everyone has muscle weakness. So again, if we were planning a clinical trial, if we were looking for a drug to improve muscle strength, we would only want to include those patients with weakness. On the other hand, if we want to see an improvement in physical activity, we wouldn't want to include patients who have severe weakness or moderate weakness, because again, this would bias the results of the study. As you can see, almost half patients had a raised uric acid level, and again, this would be a good outcome measure in terms of a blood test for the clinical trial. If we go further down to myoglobinuria, about 3/4 of patients will experience that. But then if we go for more severe complications, these are relatively rare. So again, these would not be good outcome measures for a clinical trial. And as you can see, most of those patients, we had roughly an equal distribution of males and females. So that's also useful for us to know that males and females are not particularly different. And we also had a wide age range from children through to older adults. 100% had a genetic test. Now, again, if you are planning a clinical trial, the genetic test is the gold standard for diagnosis. So for a clinical trial, one of those inclusion criteria would be a genetic test. A muscle biopsy would not necessarily be a requirement to enter a clinical trial, but if someone had had a previous muscle biopsy that you could use for trial purposes, some trials would allow that, but not all of them. Again, looking at large cohorts of patients are really important, because that tells us things about the condition that we might not have previously realised. Because with rare diseases, when you see rare complications, it can be very hard to understand that they're caused by the condition itself. And it was only when we had this big cohort of patients that we began to realise that a significant proportion have this abnormal feature in the retina at the back of the eye, which is a sort of pigmentation. You can see it here, and it's called pattern retinal dystrophy. Again, that's present in about 21% of our patients that we've screened so far. So again, this might be important. For example, if you were doing a trial of a drug that might potentially have an effect on the eye, you would want to know before you started that drug that the eye can be affected anyway. So you'd want to know what your baseline appearance is. So this is kind of really important. So doing large cohort studies are really a vital precursor to clinical trials, particularly for drug trials. And as I've said, you can then look at the genotype. So these are all the mutations in patients attending our service. These are the common ones. This is R50X, which is really very common. And this, together with the G205S, will give us a diagnosis in about 70% of patients. It's really important, again, before we do clinical trials, to understand where the mutation is in the gene affects the clinical picture. And we know that it doesn't. So that's an important bit of information. So when we write a trial protocol, we can include all patients with all mutations. We don't have to focus just on the common mutations. So I mentioned exercise. That's a possible way of improving fat burning in muscle. And I think it's something that is important to study. If you do not exercise regularly, your muscles become deconditioned, and that means your ability to burn fat is reduced, and that makes your muscles much more dependent on carbohydrate metabolism, which is where the block is. So it's not good for muscles to not exercise, particularly if you have McArdle disease, because this will increase the risk of muscle damage. On the other hand, regular aerobic exercise leads to muscle conditioning. This results in an increased blood flow to muscles, and it improves the availability of alternative fuels to fire up energy for physical activity. And again, it reduces the dependency on carbohydrate metabolism because fat is burnt more efficiently. And as a consequence, it reduces the risk of muscle damage. So in order to evaluate that, there have been some trials looking at aerobic exercise, so it's like a training program over a period of 14 weeks for one trial and 8 months for the second trial, to see what happens in people with McArdle disease. So these were really, following the strict protocol that I've outlined earlier. And what these studies showed, firstly, the point to note here is that they both had very small numbers of patients. So the first one was by Ron Haller in Texas. He studied 8 patients for 14 weeks, but they had to do between 3 and 5 aerobic sessions each week. And he was able to show that there was an improvement in their physical ability, so their work rate increased and their peak oxygen uptake increased. And not one of those patients suffered any harm from these regular training programs. Matu Munoz is one of the Spanish group of researchers, again studied 10 patients for 8 months, and again showed similar results to Ron Haller, that exercise was safe, no patient came to any harm, and their work rate increased, their output increased, so they improved. Again, if we look at our own cohort over a period of time, you can see that their average increase in walking distance improves with physical activity, with regular aerobic activity. And you can see here in some patients it went down, and these are the patients who are not doing any physical activity. So if you've got McArdle disease, and for any reason you stop doing regular aerobic exercise, you may find your symptoms get worse. What about resistance training? This is something that people with McArdle disease will have always been told absolutely not to do, but it may be very important. As I've shown you earlier, about 40% of our patients develop muscle weakness, mainly up here in the shoulder muscles, but also in the back muscles. And that tends to occur in people as they age. It also occurs in people after they've had an injury. So I've seen several patients who, for example, have had a dislocated shoulder or they fractured a limb. And then during that period of immobilization, they found there's a weakness that occurs. And unlike people who don't have McArdle disease, they struggle to build up the strength afterwards. So strength testing is really important. And also, as we get older, if we can build up strength when we're younger, or even as we age, we're going to prevent falls and frailty in old age. So again, it's about healthy living. Well, these are two colleagues from Spain, Alejandro Lucia and Alfredo Santella, who've really pioneered the work in resistance training for McArdle disease. And they have been able to show that it's safe and it's also effective, but it has to be done in a very careful way. And what they do is utilize that phosphocreatine pathway that I showed you. So this is not something that I would recommend that you try at home without guidance from your McArdle disease expert who can advise the best way for you to do this. But if you remember that it uses the 6 seconds rule, so 6 seconds, and then you must allow a minimum of 30 seconds for recovery. So I mentioned briefly the Euromac registry, which was funded by the European Union. This is a European but also global registry because it includes sites in the US and also in Turkey who are not in the EU. And it currently includes 12 sites, and it is collecting data from patients with McArdle disease and other rare glycolytic disorders. This is really important for trial readiness for McArdle disease. Now, I mentioned that another strategy to improve function might be to switch on this gene for the brain isoform in skeletal muscle. A very good friend of mine who has very sadly passed away now, John Howell, pioneered this work in sheep. He was based in Perth in Australia. And you can see these are from a paper of his. This is a slide of sheep muscle showing no phosphorylase, but when he damaged the sheep muscle, phosphorylase was being expressed. And this is the brain isoform that we talked about. So if we could find a way of switching that on, potentially that could be a strategy to improve symptoms. So one drug, which is a group of the HDAC drugs that I've mentioned earlier, is sodium valprate. It's an epilepsy drug. And so John did a trial of sodium valprate in sheep, and he did 2 separate experiments, and he found at the end of the second experiment that doing biopsies post-treatment, there were fibres that were positive for the enzyme. Now, also, Tony Andrews' group in Barcelona did some laboratory-based studies using tissues from mice with McArdle disease, and again saw a similar effect using sodium valprate. So this was the laboratory-based research, the animal-based research. Now it's time to translate this to humans. And we were very grateful that Muscular Dystrophy UK funded an open label phase 2 study of sodium valproate in people with McArdle disease. This study was run jointly with John Vissing's group in Copenhagen, and we also collaborated with Ron Haller, who was involved in the protocol preparation or development. We used the outcome measures that I've already talked about, the 12-minute walk test and a 15-minute cycle test, and also a forearm exercise test. And we compared pre and post-treatment muscle biopsies. Unfortunately, this trial did not show any benefit. We found no increase in phosphorylase in individuals after they'd been treated for 6 months. And this is the sort of example that it makes it really important to understand why you have to do human trials. You can't just put someone on a treatment when an animal study or a laboratory study shows a benefit, because in humans, things may be very different. We metabolize drugs in a different way. Now, that doesn't mean we can't utilize this strategy again for another HDAC inhibitor, for example, in the future. There may be new drugs developed that might be more efficient at doing this. So it could be just that sodium valproate just didn't get into the muscle, for example. But it was a great pilot study and it enabled us to look at the outcome measures and evaluate those in terms of their usefulness for a clinical trial. The REN 001-003 phase 1 clinical trial is currently being undertaken at the moment. It's closed to recruitment. It's funded by a company called Reneo Pharma, a small biotech company. And this trial has been running at our centre and also in Madrid with Alejandro Lucia. It's looking at the effectiveness of a drug taken once a day. It's called a PPAR inhibitor, and the drug is called REN 001. And the aim of the treatment is to improve fatty acid metabolism. So in other words, to improve fat burning. This is a phase 1 study, so it's first study of this drug in people with McArdle disease. And it was quite an intensive study. Patients were studied for 12 weeks. They had weekly assessments, including safety blood tests every week, a safety ECG every week. And then they had exercise assessments, which included cycle tests and 12-minute walk test. At the moment, I don't know the results of this trial. We should hear about it later this year. And it will be interesting to see if it's made a difference or not. Another way to upregulate fat burning is through diet. And I know that many patients have put themselves on a ketogenic diet. But again, any treatment has to be carefully evaluated, be it dietary or exercise or drug treatment. A, to make sure it's safe, and B, to really be sure it's effective and that we're not dealing with a placebo effect. So this trial, again, is a collaborative trial between our group and John Vissing's group in Copenhagen. And Nicolene Locken is the main investigator. So we are recruiting patients from London, but they're being evaluated in Copenhagen. It's a 3-month blinded, placebo-controlled crossover trial. That means people will, for the first phase, receive either treatment or placebo. They'll have a period of no treatment and then they'll switch to the other treatment. So it's a type of trial design. It's being funded by a company called Nutricia, although it's being sponsored by the University of Copenhagen. And the main outcome measure here is the 15-minute cycle test. This trial is currently open for recruitment and we'll wait to see what the outcome shows. So before I summarise with my last slide, the final thing I want to say is that actually the COVID-19 pandemic has been very challenging for clinical trials all over the world. Many trials had to pause while the pandemic was rife, or pause while there are waves of infection. I think things are improving now, so this is a good thing. But just to summarise, so translational research includes a basic science period, which may take several years, where scientists look for underlying disease mechanisms. They may test drugs or therapeutic approaches on both tissue samples and animal samples. If any benefit is found, this has to then be tested in humans, which goes on to the clinical trial phase. Clinical trials are phase 1 for safety, phase 2 for safety and efficacy, and phase 3 for efficacy and safety. In order to be ready for clinical trials, and I think this is what's really important at the moment for people with McArdle disease, is that we have registries for patients where they're registered, that we have large natural history data being collected, and that means really centralising care into specialised services. We need standardised outcome measures, and we need standardised care to ensure that anybody going into a trial is going into the trial from the same basis, from the same baseline level. So there's a lot of hope for the future. I think there's been a big explosion in biotech companies developing new treatments for rare disease. So there's a lot happening at the moment. And I think if you want to keep an eye on it, I would say look at the clinicaltrials.gov page. If you just type in McArdle disease, it will show you what trials are going on at the moment. Finally, I'd like to thank our wonderful team here at Queen Square, who've been really instrumental in collecting natural history data, providing a fantastic service for our patients, but also they've been involved in the clinical trials that I've described. And I'd like to thank IMGSD for giving me the opportunity to give this talk today. Thank you very much.